and then I'll make corrections later. Okay, so there we go. Okay, so let's talk about models. What I've seen in pain management books is they mostly talk about two different models. I'm going to show you two separate models right now. One model looks like this, and they say, well, pain is either nociceptive, or it's neuropathic. That's what they say. And they say for nociceptive pain, we have to use a certain category of drugs. Those were the same drugs listed in the presentation from Harvard Medical School. Or you have to use neuropathic drugs. Again, those were also described in the presentation from Harvard Medical School. So that's one very common model of the medical model of pain, which then becomes their springboard, so to speak, for how they manage pain. So they have to start with a model. This is one of the models that they use. From the Harvard Medical School presentation the other day, I have to go to purple right now, apparently. So from the Harvard Medical School presentation, what they said was, I think he said in that, yeah, I wrote it down. Right. So he used a slightly different model. The first presenter used a slightly different description. He said pain is either acute, chronic, or neuropathic. So that's, and these models can be merged together in the way that I've kind of done here. Most nociceptive pain can certainly be described as acute or chronic. Acute just means rapid onset, usually due to surgery or injury or trauma, and chronic has to be at least 3 to 6 months. And neuropathic is obviously neuropathic.
Now, what about the different types of pain? So we have acute pain, and acute pain signals tissue injury, just like I've told you. It says, keep it protected until all of the tissue heals. But at some point, in states where you have recurrent tissue injury, or in those where you've had permanent alterations of the nervous system, you can have pain that persists 3 months, 6 months. There are different definitions, but by and large, beyond 3 to 6 months, we call it chronic pain. And chronic pain can come from a recurrent condition that injures tissue over and over. It can have a waxing and waning pattern, or it can be chronic, persistent, and severe that never lets up. There are many different types of pain, but what underlies it is, what is the cause of the tissue injury? Now, there's a special subset of pain that happens when you injure the nervous system, and it's frighteningly common after injury. When you injure the nervous system, sometimes all the tissue injury heals. If you look at the person, if you look at the area that was injured, it looks normal. All of the tissue is healed, but there's persistent pain in that same distribution. We call that neuropathic or abnormal pain associated with nerve function.
So you can see that these are two ways of describing pain, either nociceptive or neuropathic. You can also describe it as acute, chronic, and or neuropathic, but these obviously these models kind of go together. In the presentation, so I'm going to look at my notes right now. In the presentation from Harvard Medical School, he described the treatments that they use in the medical model. Acetaminophen, just as an analgesic, NSAIDs, which are non-steroidal anti-inflammatory drugs. They're barely even anti-inflammatory drugs. All they do is reduce prostaglandin formation. Atypical drugs he describes, such as tramadol.
All right, but I'm going to focus for a minute on analgesic agents and their uses. Now, here's the range of what we have out there, and it begins with acetaminophen. It's a very good analgesic. We don't know exact mechanisms. We have some ideas of where it works in the central nervous system. It's different than the other drugs like ibuprofen, which we lump into a class called non-steroidal anti-inflammatory drugs. It turns out they're very effective pain relievers for mild to moderate pain, and they really form the cornerstone of management of pain after sports-related injuries, strains and sprains and the like. There's a group of atypical analgesics that work in different ways on different receptors, but have pretty good analgesic effects, and tramadol is one of those you might have heard about. Then there are neuropathic agents that work better for neuropathic pain, those nerve injury pains, than they do for acute pain. And gabapentin is the best known of those. Then we have an alternative group of drugs that we use in various ways, either topically or by injection. The local anesthetics, they actually work in a completely different way. They block sodium channels, and you get no conduction of the nerve traffic for a good long period of time, and we all know that. Lidocaine is the prototypic one now, but the one people know best is by its brand name Novocaine or Procaine, that's used by dentists early on. It's not used much anymore because of sensitivity reactions, and lidocaine is the more common one. It doesn't work for long periods of time, and it completely gets rid of all sensation, so it's very difficult to protect an area that's been anesthetized with a local anesthetic, and that limits their long-term use. And then finally, we're going to talk about opioid analgesics, which is where a lot of this controversy have come up, and the quintessential one, or the prototypic one, is morphine that people know best.
Neuropathic agents such as gabapentin, which would obviously fit in this category of neuropathic pain. Sorry. There we go. So neuropathic pain would get treated with gabapentin. And so the medical machine has tried to turn everything into neuropathic pain so they can add this drug. So, and I did say that the other day, they changed their models based on what drugs they want to use, when in fact they should be creating accurate models and then implementing accurate treatments based on those accurate models. The medical profession doesn't do that. They look at what drugs they have available, and then they look at the patient and say, well, we're going to make this drug fit your problem, even if it means we have to rewrite the science in order to justify this. That's exactly what they've done with fibromyalgia. And that's why the medical management of fibromyalgia includes neuropathic drugs, even though it's not a neuropathic disease. They looked hard and they looked everywhere to find any evidence in animal models, for example, of nerve injury in patients or models of fibromyalgia. They finally found it, and that now they get to use this class of drugs, even though it's irrelevant for the basic pathophysiology of fibromyalgia. The next group, local anesthetic agents like lidocaine. These act on ion channels, especially sodium channels. And then opioids, of course. So the political purpose of this presentation from Harvard Medical School appears to have been defending the use of opioids. I mean, that's all they did during the entire presentation. So again, and this is what we learned in medical school. That's why when I saw this list in this guy's presentation, I thought, wow, this wasn't just our medical school. This is really, apparently, the canonized medical model is acetaminophen, NSAIDs, atypical drugs, tramadol, neuropathic agents like gabapentin, local anesthetics, and opioids. I mean, when these people, medical pain specialists, when they think of pain, this is what they think of. And then, of course, you can go into more invasive procedures. Well, and sometimes those are good. You know, sometimes like nerve root blocks with anesthetics, or nerve root ablation, or surgery, or implanting devices, or cutting nerves, or amputating body parts for people who have really severe chronic pain. I mean, we can certainly go beyond this list. I don't know that most of us would want to, because they involve permanent surgical interventions or interventions with permanent consequences. Okay, so I did make some progress there. And just to be clear, what I want to state is that this model is not accurate. It's accurate, at best it's accurate for acute pain, but it's not accurate for chronic pain. it's not accurate for, sorry, I have to, something about that wasn't quite right. It either wasn't right, what I just said either wasn't right, it's not the way that I want to say it, or it is right in the way that they say it. And that's probably where it is for me. The way that I just said that is correct based on the medical model, but it's not correct based on the way that I think it should be said. And I don't think I have to write that down right now, because I think it's going to become obvious in just a moment. But maybe I'll go ahead and write it down so I don't lose it. Okay, so I've talked about these two models. I talked about the little bit of comment about the Harvard Medical School presentation from 2018. And now I'm going to talk about these two articles. The second of the two articles, I'm only going to look over it really quickly. The first one may require a little more time, but I already reviewed it, so I don't really feel a need. I don't feel the need, and I'm not going to go through the article in much detail. That's a little bit of leftover water and honey from a previous beverage, which was coffee and protein. Okay, so let's see, where am I going with this right now? Oh, here's what I wanted to write down, and you'll see it represented in the title of this article. Remember, this exercise right now is pretty semantic. I acknowledge that. But it's not simply semantic. The medical mismanagement of chronic pain hinges on an error in logic, which I think I'm just now at the cusp of being able to decipher. And I think that this article exemplified that error. And that's where I'm going with this. So remember, we're talking about the medical mismanagement of chronic pain. Why does it persist? How did it happen? Why is it so powerful based on its persistence? How can this model of pain management be so ineffective and yet so stable? Like, why haven't they changed it? So where's the error that locks people into this model even though it doesn't work? That's the question that I'm trying to answer here.